Right, so good morning everybody on the telephones and on the computers. Welcome to the Assistant Practitioner webinar. I'm Mike Bailey, Career Progression Programme Manager with Health Education Kent, Surrey and Sussex. So I deal with a lot of the bands 1 to 4 and it fits in well with the Assistant Practitioner work. I'd just like to introduce, or get them to introduce themselves, two work colleagues who have kindly come in to do presentations today on the Assistant Practitioner and how they've developed it within their organisations. So I'll hand over to Barbara.
My name is Barbara Gosford. I'm Clinical Education Manager for East Sussex Healthcare NHS Trust.
Joanna Kimera, Surrey County Council. I'm a Training and Development Service Partner for Adult Social Care.
So what we're going to get today is a bit of a flavour about how the two different types of organisations have developed the Assistant Practitioner role. Currently, health-wise, across the region, across Kent, Surrey and Sussex, we've apparently, looking at the stats, about 116 assistant practitioners that are actually enrolled. And really, so today we want to give you a bit of a flavour around the assistant practitioner. So, roll on. What we're going to cover content-wise is obviously the role of the assistant practitioner. What are some of the benefits of the assistant practitioner if it's done well? Because we will actually look at some of the barriers and challenges a bit later on in the actual webinar today. We're going to look at, like I say, health and social care perspectives on developing the role, tailoring of the assistant practitioner role. As I say, the barriers and challenges and future steps of what we're kind of looking at, really. So the idea today is that we will do some presentations on how they develop them, but also there'll be room and opportunity for questions and answer session at the end. We'll endeavour to answer your questions. If we're not able to answer them, we'll take them away and get back to you. The webinar today is being recorded, so it will be actually going on our website in the near distant future. So I wanted to just explain some of the actual national, regional, local drivers really around this. There's quite a big push, as probably people are aware, on the Band 1 to 4 workforce, and with the Health Education England, which is our wider body, has the Talent for Care strategy, which has 3 strands to it. Get in, so how do we get people into the NHS, get on, what training and development do they need to do, what's there, and go further, thinking about what career progression opportunities are available for them. So again, the assistant practitioner work fits in very well with the Talent for Care strategy, and also as well Health Education England's widening participation strategy. It also links in a lot with the new Shaping for Care review, and you probably heard a lot of discussion about whether there's going to be a defined care role at Band 3, which is still looking at the moment nationally. And what's quite interesting within this, within the assistant practitioner workforce, is just to let you know that there is a new assistant practitioner coordinators network that's being established nationally, which will be an expert reference group around assistant practitioners. And the specific areas it will look at are education pathways, funding to support the role in service, service delivery areas that the role can be utilised within, and organisational development and workforce planning. How can you actually build these roles effectively into your skills mix, as it says on the screen there, and actually maximise the resources as well. From this as well, what we hope from today's webinar is that we will also help inform a regional task and finish group that will be developed around the assistant practitioner role. So again, we recognise that there are areas of really good regional practice that we can actually learn from. There's a lot of different organisations that develop assistant practitioners. Can we bring all that together, and can we bring all those resources together rather than individual organisations having to kind of map it themselves and work out the process themselves? So without further ado, what I'd like to do is hand over to Barbara for the perspective from East Sussex Healthcare, and also Joanna for the perspective from Surrey County Council.
Good afternoon, everybody. Within the East Sussex Healthcare NHS Trust, obviously we have considered the need for associate practitioner roles. So from areas that made us consider that, from 2013, all pre-registration nursing programmes were now at degree level. There's a national and local shortage of registered nurses, local recruitment challenges, the age profile of our current workforce, international recruitment sources are sort of drying up, development programme required for overseas nurses, so when we get those nurses in, They need additional training to ensure that they're fit for purpose in practice. And the return to nursing practice opportunities are quite a low intake. Probably there aren't the number of people out there that really want to come back to nursing. So an AP role, what is an AP role? So it's a highly skilled role. It's at a band 4. The role is designed by the employer, so it's a role that the individual employer considers that they would like, that fits in with their service development. And they develop that role, and then they go in partnership with the university and develop that role through higher education and practice. So the specific scope of practice, so each individual who goes onto the programme will be ensured that they know where their role is going to develop, although at the very beginning of the role it is a working practice, but there is the outline of what that role will be. The assistant practitioner role is a complement to the clinical skill mix, and it enables a career progression opportunity for healthcare support workers. So the benefits of an AP role, it bridges the skills gap between healthcare support worker role and a registered nurse role or registered AHP role. Frees up registered nursing and AHPs to focus on complex care. They are highly skilled individuals with a very good underpinning knowledge, so they're more, they question more, they're reflective and critical thinkers in specific clinical areas. There can be role models to other healthcare support workers, improved patient care, so raising staff morale through professional and personal development opportunities. A lot of healthcare support workers say, well, I got to where I am, what is there now for me? To go on to registered professional training, there is now a wider gap with all the degree entry qualifications being required now. Mike has already talked about the national and local policy drivers, and we're clearly providing a career development opportunity for individuals. So the way that we develop AP roles, they're developed in service by the clinical area, and the areas will be looking as to how they want to develop their skill mix, looking at what individuals that they already have and seeing whether they can develop those individuals. So across ESHT we have a range of AP roles. So we have some in theatres, surgical assessment, eye clinic, surgery, urology. We have one in public health, we have several in community nursing, some in advanced recovery from surgery, we have gynae, we have outpatients, we have stroke. And we're very, very proud that we have one who developed to a band 4 in a moving and handling trainer role, and that individual undertook their development within an AHP area. So developing the AHP roles, we provide recruitment opportunities. We do that within house. We work with individuals to provide them with as much information that this is not just the band 4 course as it has been affectionately known. It is a new role. It's not about getting more money for doing the same job. That often takes quite a little bit of getting through, and within that you can work with the healthcare support workers so that they can decide, is that something I want to do, or do I want to stay where I am, or do I want to perhaps looking at doing a registered professional role. We tailor the roles and identify the skills. That's how the service can identify where they want to go with that role. Within my role, I speak with the line managers, the matrons, the clinical leads, so that there can be identified budget for a band 4 role at the end of the programme. So we're not developing people up, we're not setting people up to develop something. It's a hard course to get to the end of it and not have a role. We have a robust internal recruitment process, and we support the healthcare support workers who've been successful within that and secured the Health Education Kent Surrey Sussex Educational Commission, which is the way that our programme is funded through, and we support them through the university interview, and we have a very clear partnership with our HEI provider, which is the University of Brighton. We identify at the time of the recruitment a work-based supervisor, which each AP student needs. So we look at, is that person going to be there? They're in for the long haul. It's a 2-year programme, and they need to have the relevant training to support that individual. There is, at the initial discussion point, we plan the off-duty. The requirements of the course, which is attending the course for 1 day during the 2 semester times, and we look at the supernumerary time that's required around 2 7.5-hour shifts. We have acute and community within our organisation, so I work very clearly with the matrons and the team leads to which is the best way to meet the needs of the service for the individual student AP to get their supernumerary learning time. And we keep our AP students on the existing salary, so they stay within their existing area and they have their existing salary. We have a clear learning contract, so that's in addition to their existing employment contract. So they remain in the same clinical area for the period of their training. There is also support from my clinical education team as an addition to the work-based supervisor and the support of the matron team lead in the clinical area that they are. There is support from myself and my team with clinical skills development. Our HEI provider does have a skills bank, but not every role is catered for. So we will look at the Skills for Health skills bank, and we'll work out is the skills there, how can we assess it, and how can we have the assessment at the level required for the programme. The work-based learning projects that are undertaken in Year 2, I would say without exception, they have been developed and they have been taken forward within the clinical area for the MP to take forward within their role. And that's something nice and tangible that the service can see that the individual has done, and the individual can be very proud to say that's that piece of work that I did, which is either generally around a patient information leaflet, a staff information leaflet, which is generally where assessing what needs to be done within the scope of practice for that role takes them. So the career progression for the APs, there's clear training and development opportunities we see. Within the learning contract, we get them to sign up to continue within the role for 2 years. This is around the service having a payback time and the individual being able to consolidate within their role. We do understand that for some individuals, really they may wish to go on to a professional registrations qualification, and that is the route through, although we would not want them to go on to that straight away, and that has happened to us in the past. We also, within sort of that 2 years, it's a good opportunity for them really to grasp what they need to do within that time. Additional skills development for the role. The role is work in progress, and it does give an opportunity for the scope of practice, the skills that they have specifically developed, to be embedded and to consider if there's anything else that needs to be refined within that role. Development of new scope of practice. This is where we see that an individual who has had the foundation degree, they've developed a specific scope of practice along with that role, they may well which, well, I'd like to go and work in a different area. So there is an availability, and we do have that happening at the moment, where an individual is developing a new scope of practice and services supporting them to do that. As I've said, there is development onto BSc nursing or into another HE registered qualification, and we have had the opportunity to have career progression for a Band 5 role. So barriers and challenges to this is it's 2 years investment by a clinical area. The backfill that we receive from HEKSS is quite limited, so it doesn't enable replacing like for like. Most service areas consider that is something that they are happy to take, because the individual has the 3 days if it's on a 7.5 hour rotation. That is somebody who's doing full time, that they will be working in their substantive role, their HCA role for part of the time, but they are getting somebody who's developing higher level skills, so that's seen as a very win-win situation. Salary and loss of the healthcare support worker while at university and during supernumerary time relates to what I have just said. But you get a higher level of person who's going to come back and question more. The work-based supervisor time, this is always quite a challenge for the work-based supervisor to be continuing their role. There hasn't been any particular protected time for this, but we have very motivated individuals that take on this role because they see the benefits of what that Band 4 role will be at the end. We have had in the very beginning the APs, we have a few initially moving straight onto a BSc nursing programme, and we've had keeping the Band 4 salary within the service budget for when that person completes at the end, around the services changing from when the AP started their programme to when they have completed their programme. We've had, within our organisation, like with any other organisation, we've had many, many changes during the FD programme, and it is very important to keep in touch with the FD student to ensure that they are being supported so that they can have focus to complete their programme, even though lots of things are changing around. So there is a cost to the trust in developing the role, as we only have a nominal backfill fee. There's some resistance from registered nurses and from other healthcare support workers in types of, well, it's the old enrollment nurse course. I'm already doing that anyway, so I don't know why you're doing the programme, because I'm already doing the course. So within our next steps, what we are looking at developing is very clear guidelines and documentation to assist within developing the AP roles. So we're having a workforce strategy offshoot to actually look at that because of the numbers that we have got through. Sharing scopes of practice around and the benefits of the role. Evaluation of the AP roles, the benefits for patient safety, cost saving, staffing levels within the skill mix. It has proven very, very effective when having, for a matron or a team lead to know that they've got a number of healthcare support workers, they've got an AP, so they can continue with that level of care that's required to enable the registered practitioners to be filled up. Workforce planning, we're getting better at looking at the workforce planning and linking it very much in to be accurate with the Education Commission that we're asking HSS of. We're looking at developing the communities of practice for the assistant practitioners within the healthcare support worker arena, because if you're not, as an organisation, going to develop something, the APs will go and develop their own communities of practice. So we're working very hard at that. And the way that we're doing it in ESHT is we've got a robust healthcare support worker forum, which is run by an EP, and getting more people to come on board and realise that this is for them too. And within that, a forum to share experiences of learning, so others can feel that where possibly they are one in one service, there are other colleagues across the trust. And we would very much like to, and we are looking at a conference as a celebration event, and we hope possibly that that's something we can work with HSS, develop and host within the profession. A couple of quotes which I have been given from some of the APs are, the foundation has enabled us to realise my potential. They have felt very proud that what they have been able to do and the care that they can now provide for patients. It is a very hard programme. They didn't possibly realise it was as hard, but they're very proud that they've been able to achieve their foundation degree and to get their band 4.
Great. Just wondered, if you just pause it there for a second and see if there's any questions on the line or computers for Barbara.
Yeah, I've got a couple of questions. Can you hear me okay?
Very, very low, but yeah.
Let me plug myself back in. One of the things I was wanting to know about is the fact that you were saying that you were looking at sort of creating a guideline to sort of assist with their role. How did you go about that, and have you managed to sort of get that all sorted yet?
I didn't hear the question.
Sorry, can you repeat the question? I think it went a bit muffled.
Sorry, say that again.
Can you repeat the question? I think it went a bit muffled.
Absolutely. So one of the questions was, first of all, you were talking about quite a few things, so I've got quite a few questions. So you said that you had to create a role that you were getting more money, but not for doing the same role. How did you go about doing that?
Sorry, I'm not sure what you're asking.
So did you end up having to create a new job description? How did you differentiate between the current role that they were doing and expanding their role that they're now doing as a band 4? How did you sell?
Yeah, very much. We have a generic assistant practitioner job description, and the way that we develop is through the scope of practice. So that's the specific skills that the individual will be undertaken. So unlike a lot of their healthcare support worker roles, they're very generic.
Yeah.
This is an individual that will be doing a specific set of competency skills within their role. And that's what they learn within their programme, and that's what we assess them from the practice side of their course.
Brilliant.
From as I said, from some of the roles that we've developed, so we've got roles within urology, within stroke, so it all relates to where there has been seen a skills gap within that specific service. So the one in urology is around a clinic role, and so when you consider an individual that's coming into a clinic, what does the majority of people that come through that clinic require? So a lot of it is around assessment, which the AP can do, and then there are some of the specific tasks. So there could be bladder scanning, there could be catheterization. So it enables the specialists within that area to concentrate on the higher end of that role. Does that answer your question?
Yeah, no, it does. So the competencies that they've got, does that come from the university, or did you write those competencies for their skills achievement?
The competencies within the foundation health and social care programme that we use, which is with the University of Brighton.
Yep.
The year 1 has skills which enables the individual to come up to that higher level, more critical thinker. So the skills around infection control, communication, governance, etc. Within year 2, it's the specific skills that we would want that individual to undertake within their scope of practice. So we would consider what those skills would be, and then we put that in that package. the university have some skills assessed at the level, and also we may take some skills from Skills for Health.
Yep.
Where there haven't been the skills that aren't available, we look at what that skill is, and then we would put the assessment criteria around that skill.
Thank you very much.
Are there any other questions for Barbara?
Yes, please. It's Helen O'Keefe from East Kent Hospitals. I'm sorry, I joined a little bit, and so I didn't quite catch the name of the presenter or where she was working.
Oh, hello. I'm Barbara Gosden. I'm the Clinical Education Manager from East Sussex Healthcare NHS Trust.
Right, so is that a community
provider? No, we are both. We're both acute and we're both community.
Oh, I see. Okay, thank you. Well, my role is acting Deputy Chief Nurse at East Kent Hospitals, and I've got a few questions because we've been commissioning 20 commissioned places for the foundation degree every year since about 2000. So we've got a critical mass of associate practitioners within the organisation now, and so we've learned an awful lot over the last 8-9 years, and I've just wondered how many you've got in the organisation that are working as associate practitioners now.
Right. We became an integrated organisation in 2010-11, and from that period of time, we have had 38 commissions, and we have got. Sorry, that was what I was going through this morning. We have possibly got about 20 working within the organisation. That possibly might seem a low number, but initially the number was very low. Then within the acute side of the organisation, they went up to 1 year in 2011. They went up to, on the cusp of when the organisations joined, they went up to 16. And at that point, there wasn't really anybody looking at keeping it together for what would happen within the 2 years to ensure that people had got a job at the end of it. And there also was a slight disconnect between what was happening at the university and what was happening in the trust. So after that, there were people that came out of that programme that perhaps didn't have a scope of practice that fitted to where the clinical areas wanted them to be. So the following year, the commission numbers went down. We made the decision for the numbers to go down very much lower and to work very much with the clinical areas to ensure that the individual was very supported to come out with something robust that would fit the service at the end. And so we have then been every year after that, we've had quite low numbers. We've had 4s and 5s, and we've been very clear with the individuals that go onto the programme that the service has got all the structure in place, and there is money in the budget for that individual to have a band 4 role on successfully completing the programme. So we've now taken the leap that we're going to go for 2016, and we're just waiting obviously for the commission numbers. We're going to go back up to 10 because it's seen as being very successful because the support has been in place. Does that sort of answer your question?
Yes, I just wondered how many you had really. I've got 3 more questions. Is it okay to ask 3 more?
Yeah, feel free.
Thank you. The first question is, as an acute organisation, we have to undertake 6-monthly full staffing reviews and monthly reports to our trust board on filled versus actual versus planned filled hours for registered nurses and for associate healthcare assistants. we watch very closely the impact that the associate practitioner role has on our skill mix, because of course it's essentially a higher level support worker role. I just wondered how you'd handled that as an organisation, because we've seen obviously our skill mix fall in critical areas like theatres, outpatients, medicine, surgery, paediatrics, stroke, all the areas where we've got these roles. And there's a kind of tipping point, isn't there, that, you know, where you can go no further. I just wondered how your board has helped shape what that tipping point might be.
I think those are conversations that will be having, because we haven't got the large numbers of the APs yet. So it hasn't actually made, I don't think that's something we have had to consider to date. But within the workforce stream that we're going to have, those will be conversations that we'll be needing. And I certainly think that some of the conversations that we have had is about where we cap the level of the skill, and that we are not getting the APs to do things really that are, because the role does transcend across, that we're not going to get the APs to do anything that we really think will actually not be appropriate. So I think you're more advanced than we are within your numbers.
Yeah, I just so that's really interesting, because it's something that I think we will have to challenge ourselves with in the longer term, because I think we're still sitting at 60-40 on our acute wards, but in some areas we want to push that down, because the associate practitioner role is performing some of the tasks that were previously within the remit of the registered nurse, and that includes some of the medicines management. And I just wondered how far you were taking the medicines management skills within the role. Have you gone there, or are you steering clear of that?
I think we're erring very cautious on the side of medicines management, and we certainly wouldn't be wanting, you know, something being put into an open vein, or when we've looked very much at the theatre roles, we're very clear within the level of the basket cases that we would be those roles would be within, to enable very clearly the scope of practice not to be stepped outside of. So I think we are erring very cautious, and we are having those conversations. I think service are quite keen to push, but I think in terms of governance and patient safety, we are beginning to have those conversations as we get more and more through. So I think you're more advanced and in having to have those conversations, whereas we're just considering them.
Yeah, and I think it is really interesting, the medicines management element, because that's the one that's. I think for us, we have learned that it's easier certainly to design the role for an individual associate practitioner around the needs of the service, and where the role works best, it is large predictive care, and in elective areas, in theatres, elective surgical wards, paediatrics in some cases, and it's much more difficult in the acute medical ward, although it has worked in areas like stroke. But we do include, or in the second year, some competencies around developing skills in medicines management, and it's participating in the administration. But when they've completed their foundation degree and they're in a Band 4 role, we expose them to more in-depth training if they're capable, and if the role requires it, for them to check medications and administer to patients. And this is working really well, and I think it's helping staff see enough for us to realise some of the benefits of the role in a way that we weren't always previously capturing. My last question to you, if I can just ask the last one, is how do you handle the expectation amongst some associate practitioners that they will then be entitled to secondment to nurse training? I mean, our view is that the associate practitioner, although it's not a ceiling, a career ceiling, it is a role in its own right, and it's not an automatic progression to nursing. But we have had a lot of interest from our associate practitioners to be seconded into nurse training, and we're pushing back a little bit because it would mean that we're training nurses for 5 years. We're not keeping them as associate practitioners. So I just wondered if that was a particular difficulty for you.
Exactly. We have a learning contract, so when we do the internal recruitment for the interest, we talk about what the role is and our expectations and the investment, and we also talk to them about going on to do BSc nursing or an AHP registration, and really what is it that they want to do. So we will have those frank conversations very much at the beginning. We very often you get people who say, well, no, actually I do want to be a nurse, I do want to be an OT, and then you can support people within that development. For the vast majority, they say, no, it's the AEP role that I want to do. The challenge that you often get is when they go to university and you're exposing them to education and something that they thought possibly wasn't available to them, then that's when they think, well, actually, possibly it is what I want to do. But we tie them into a 2-year learning contract, so we do get some payback within service, because there's the big investment by service, and then they want that role up and running. So we have been quite canny around that, and totally I agree. 5 years to do nurse training is a long way in, when it can be shortened by them doing an access course or something.
Yeah. Thank you.
I just wondered as well, as Mike again, just to say that if people have got any queries around what's happening in the wider remit, because I know we're listening for 2 people today, but if you want me to find out further information about what other people are doing, my email address is at the end of the presentation, and by all means email me with questions, and then I can write out to other organisations to find out what they've done, and also check nationally about any good areas of practice as well, if that will help.
Yes, please.
Okay. So any other queries before we hand on to Joanna, or questions?
Yes, please. It's Jo Embleton, Deputy Director of Nursing at the Royal Surrey. Can I just ask if you've done any work about the associate practitioners becoming mentors for healthcare assistants through the care certificate?
We're very much looking at that, and I am actually, as we speak, writing a job description with my lead for bands 1 to 4, and we will be putting out an advert internally within the trust for just that thing. So yes, there's a wealth of information there and resource, and yes, very much that's what we're hoping to have somebody in post early by next year to support band 1 to 4 lead.
That's interesting, thank you.
Would you be happy to share that?
Absolutely.
Yeah, great. Great. Any other final questions before I hand over to Joanna? Okay. Right, I'm going to hand over to Joanna now from Surrey County Council to give us quite a different perspective. Great.
Okay, so I'm Joanna Kimmer. I'm Training and Development Service Partner for Adult Social Care, and I will talk to you about assistant practitioner type roles within local authority. So overview first. Social care landscape is quite different to the health one, and with the Care Act implementation in 2014, we had to make some changes. However, the assistant practitioner roles have been quite established for a while within the local authority. It is normally quite generic, and we tend to not to send people to university because they create majority of our workforce within the assessment teams. I'll talk about it a little bit later on. When people join us in assistant practitioner type roles, they undergo a 4 or 5 week structured induction program, and they also have a quite rigid CPD and refresher course catalogue that they have to complete either annually or every 2 years, etc. The pay is equivalent to NHS bands 4 and 5, and it's very often seen as a progression route for care staff and reablement staff, either within local authority or independent sector. And very often, those people who are in those roles, then they will progress either to social work degree or to occupational therapy. The different roles within those assistant practitioner type roles, in Surrey we call them social care assistants and senior social care assistants, but other local authorities would have social work assistant, senior social work assistant, occupational therapy assistant, senior occupational therapy assistant. And you're probably aware that in Surrey, our mental health service is an integrated service. So we have integrated teams that consist of both health staff and social care staff. Some of those mental health workers or enabling independence workers, they fall into the category of assistant practitioners. And we also have dedicated carers leads, so people who support carers, family carers. So the responsibilities of assistant practitioner type worker would mostly be around assessment, and it would be holistic assessment of needs of both individuals and carers in different settings. So it could be in the hospital setting, it could be in person's own home, it could be in a care home, nursing home. So it depends on the individual. They also manage casework. They conduct support planning, they conduct reviews, they provide a range of information and advice to the individuals and carers. They also identify and support safeguarding investigations. We wouldn't expect assistant practitioners to conduct the investigations themselves. That would be something that qualified member of staff would do. They would also identify cases eligible for continuing healthcare, and in their scope of responsibility, they would also prescribe simple equipment. Again, small pieces of equipment, not hoists, that would fall into occupational therapy. They would also enable access to services, for example, reablement, care support services, and they would have duty cover responsibilities as well. Benefits of assistant practitioners, they definitely manage public demand. I mentioned at the beginning that with implementation of the Care Act 2014 this year in April, every person can ask for assessment. To manage that demand, we rely quite heavily on assistant practitioner type roles to conduct proportionate assessment. They would also manage business as usual work, and that in return will allow qualified staff to concentrate on specialist and complex areas. It also allows us to suitably distribute tasks. It's cost effective and value for money. The barriers for assistant practitioners, the progression route is quite limited. We see We do have some support for assistant practitioners who would like to study for university degree, but we have very limited placements. So very often this role is seen as dead end, and that's something that we are trying to work with higher education institutions, universities, to develop the vocational route, APA route, so people's experience is recognized. Very often in the course of their work, they come across very difficult cases. They would be working in multidisciplinary teams, and that is not necessarily recognized. The developing subject matter expertise may be quite limited. Very often, in Surrey, I can talk for Surrey, but I think in general in local authorities, assistant practitioners tend to be generic, and this subject matter expertise is seen as qualified practitioner's role. We are trying to develop some CPD for assistant practitioners, but it's also working with the qualified staff to recognize that. And of course, we have unfilled positions because we rely very heavily on assistant practitioners in our assessment teams. We have 11 locality teams in Surrey and 5 hospital teams. We do have some unfilled positions, and as unfortunately social work and occupational therapy are by us recognized as hard positions to fill, we are relying on assistant practitioners more and more, and unfortunately we have quite a lot of unfilled positions there as well. The scope for integrated roles, it's something that I tried to have a little think about, because it might be quite difficult, especially after Barbara's talk, how specific skills are recognized within the roles in health and how generic our roles are. But the pay is comparable, and maybe those people who are at the beginning of their journey in assistant practitioner role, we could actually think of sharing vacancies between local authorities and NHS. Maybe short-term secondments could be also something that we could explore, especially that we tried a little project already on short-term secondments with mental health, and that was quite successful. So maybe with acute trusts, why not? Borrowing day shift work, that's something again could be explored, but requires in-depth conversations. But certainly the sharing of training, maybe joint commissioning, joint delivery, and certainly working with higher education institutions on APA routes and vocational routes if there is an interest. Thank you very much.
Okay, thank you for that, Joanna. The questions for Joanna. Stunned silence.
I think it's quite different landscape.
Yeah.
So
are there any significant lessons learned, you think, from going through this process? Because you've done it for quite a long time. So any of those you'd share?
Plan progression routes at the beginning, because it's very difficult to plan progression route for those people who are in those roles for a really long time. So we have some workers that have been assistant practitioners for years, and they're still in that assistant practitioner role. So I think that either working with higher education institutions, universities, or planning those progression routes ahead of time.
And how they evaluated the success of them in service?
We can manage the demand of public, and if we think about it, we do thousands upon thousands of assessments every month. They are out nearly every day, working. Sometimes we have 5 hospital teams and we have 11 locality teams. The demand is still there, and we rely on them very, very heavily, very heavily. Without them, local authority would not be able to conduct assessments.
Thank you, that's really helpful. Are there any other questions to the group? Silence.
You mentioned at the very beginning about a working group that you've got going on with regards to the assistant practitioner role. How do we get hold of that or feed into that?
Right. My suggestion was that was the next thing I was going to come on to. What my suggestion is that, like, from today, that really we start to think about what are some of the key issues and some of the areas that you want Health Education Kent, Surrey and Sussex to look at. We talk about it we have a career progression programme board, and we talk about it in there, but it'd be good to get your thoughts and feelings about how we can best support this agenda, because we will feed into that national group and as well. So, like, if you come to, like I say, email myself, and we can look at the best way to communicate that and to get anybody's thoughts or feedback, not only into the national work, but also into what we need to do locally.
Yeah.
Now, in the new year, there will be potentially be a national conference on assistant practitioners and the development of the assistant practitioner. They haven't got a date for that set yet, but they'll be coming out with a programme probably over the next month and a half, and then we'll be sending that out to organisations to get feedback about content, but also as well to actually see if people want to sign up to it. So I'll keep you informed about that as well.
Lovely.
Thank you.
Thank you.
Is there a possibility of sharing work across our local network? Because we've been doing this for about 5 years, and I know from very painful experience, when you're starting off or you've got competencies that you've got to develop starting from scratch, if there's things that we can share would be most beneficial. So, for instance, I'd be very interested in East Kent's medicines management.
Yes, I'm happy to
Yeah,
share that.
absolutely. And I think, so what would be useful is if you've got any requests for resources that you think would be really useful if they exist across the patch, I'm more than happy to be the conduit that kind of shares those. But also as well, if you've got anything that you think would be good to share, again, that would be really useful. We have been looking about where we actually could centrally put some of these resources, and we've been having some difficulty from the health education side about where we can actually store it, but that's an ongoing discussion. But if we can actually get it onto somewhere centrally, it might be quite a good resource. Well, it will be a good resource to actually have there. So we'll continue on with that, but by all means, send through any requests or anything that thinks good practice. Is that all right by people? Is there any other questions?
No, lovely. Thank you.
Thank you.
No
Thank
problem.
you.
Well, thanks to Barbara and Joanna today for their time, and thanks for joining us on the webinar.
Thanks very much.
Thank you.
Thank you.
Thank you.
Bye. Bye.